Thank you. Thank you very much, Bhavna and eCancer for being with us at our hospital. Uh, it is indeed a privilege to deliver this talk, which is in memory of Gordon McVie and Umberto Veronese. And the topic that I'm supposed to cover is sustainable cancer care, as I have added a little addendum to that over and above what you mentioned about sustainable cancer care, the Indian national model, as to what have we done here to make it sustainable and how far have we gone on that road. Uh, so I will divide my talk into three components. The first and the foremost component of any cancer care is, if you have evaluated the magnitude of problem, you either look at what has been the trend. Is it rising? If it is rising, at what rate? Then you need to create infrastructure which will cover for at least next 1 or 2 decades, or keep that model scalable so that additional numbers could be included and accommodated, or take steps to see that the numbers are down, that they are kept down as much as possible, which is part of sustainable cancer care. The second component would be access to care, as we have planned in India. And finally, some thoughts on affordable research and solutions that we formulate, looking at the gaps that we have identified earlier from our various surveys. So let's look at keeping the numbers down and saving lives as part of prevention and screening. Some numbers, which all of you know, but essentially that there are less and less numbers as we go away from metropolitan or urban locale, from 100 to 65 to 48, and these numbers have remained relatively constant for the last 15 years, which is unique for India. Unlike BRIC countries other than India, where the actual incidence itself is rising in each of these habitats. Unlike that, we have had not much of change over the last 15, 20 years in these numbers. Our rural numbers have remained 48, the semi-urban have remained at 65, and urban at 100. The only thing that has changed is that the urbanization has increased its speed from 5% in every 10-year census about 20 years ago to about 8-9% in the last census. So that bit would add more numbers as part of urban, so more numbers coming in. So obviously the absolute numbers would increase. Our problem in the last point is rather that survival of those who get it is 50% overall, whereas that in US would be 70-75%. But in pursuit of increasing this 50% to 70-75%, it shouldn't so happen that our 100 becomes 300 or 360. That would be a lost battle. If we were to keep the numbers at 100 and yet have the survival at 70-75%, that would be a success story. So a quick review of what all things have happened on prevention to keep the numbers down. Of these 100 in urban, or whatever numbers I mentioned in rural pockets, 40% are tobacco related, 15% are obesity related, and another 15% are infection related. We already have some success stories, at least in Maharashtra, banning in urban localities, banning the gutka, the oral chewable form of tobacco with some nice coverings and nice way of selling it, has been banned, although you would still find it in some pockets. But that itself has shown about 11% reduction in the first 3 years, within 3 years of that ban, in oral cancer. So it is possible to say the way for smoking, we have solid data to say that if smoking is reduced, I'm sure there is a reduction in lung cancer. Similar thing is also seen for oral cancer, and we should take that forward in all states. As far as infections go, the general statement will not be wrong that infection-related cancers are reducing at breakneck speed. Cervical cancer is reduced in Mumbai from 26 per 100,000 about 25 years ago to 7 per 100,000 in the last data that came about 3 years ago. So there is a rapid reduction in cervical cancer. I'm not going to go into the details. Similar reduction is also seen in urban India of related to stomach cancer, penile cancer. So there is a reduction related to infection-related cancers, and a lot of it is related to personal hygiene. In Northeast, we have a lot of nasopharyngeal cancer, obviously related to poor preservation of meat, smoked meat, which harbors Epstein-Barr virus, and the nasopharyngeal cancer is pretty high there, anywhere up to about 12 per 100,000. Whereas if you look at Mumbai, that number would be somewhere like 0.002 per 100,000. So a huge difference between the two, entirely related to the smoked meat, which otherwise is safe enough if properly preserved. So good food preservation facilities in these regions would make a big difference. Obesity, diet-related, dedicated cycle tracks and walking cities I'm not going to touch upon that either, but that is the kind of cancer that is on the rise in urban India. Screening, as far as the advice, or we are in an advisory capacity with the Department of Health, and the advice is very strong as far as screening is concerned, unless there is solid randomized evidence in reduction in mortality without much of overdiagnosis, we should adopt that policy. Towards that, we have two studies which have looked at, which I will allude to, related to cervical cancer and breast cancer. But it is fortunate that we don't screen for prostate cancer, we don't screen for lung cancer, and we don't screen for colorectal cancer, that being rare cancer. So with those numbers down, our overall numbers of all cancers have reduced. That's the evidence for breast cancer at 20 years. There was hardly any overdiagnosis at the end of 15 years of follow-up. Similar is the number for cervical cancer. There is a little additional cancer diagnosed earlier on in the randomized study that was done in Mumbai with Dr. Mitra. And you find that the cervical cancer did show a 1/3 reduction, somewhere close to about 32% reduction in deaths related to cervical cancer, and a similar reduction in breast cancer mortality above 50 by plain simple physical examination done by healthcare workers trained for 2 months and then left in population. I then move on to access to care. We have already created some hubs and spokes, and the hub and spoke model based on our mapping of whole of India for various facilities that are presently available as part of National Cancer Grid. And wherever these facilities did not exist, we have created hubs. You will find one in Mumbai, which is already there earlier, in New Bombay. And there are 2 facilities in Punjab, 2 in Uttar Pradesh, 1 in Bihar, 1 is about to come up in Orissa, there is 1 in Assam, and there is 1 in Andhra Pradesh. So all these facilities are there, and in addition, we are helping many governments, whether it is Maharashtra government, Uttar Pradesh, West Bengal, Bihar, Jammu and Kashmir, and Punjab, in creating workforce so that cancer is adequately treated closer to home for all patients. That's the picture of National Cancer Grid contributors, and there are various places where we are attempting to get uniform care. Ramesh has been doing a sterling job in that, and the success is already evident by the uniform care that is being delivered across the country. Wherever there are gaps, we are now systematically creating a hub and spoke model and advising various state governments to do it. Typically, for every 50 million population, we have advised a hub, and it is expected that it would be a 350-bedded facility at a cost of about $80 million. That's the capex, or 650 crores of rupees. And at an OPEX of about 90 crores, that's about $12 million. But if we were to generate revenue with the whole spectrum of society, and I will allude to what could be done at institution level once I'm done with what is being planned for the national level, you will understand that if 50 to 70% of revenue is generated in each institute, then we are looking at much less OPEX for a hub, and similarly, much less OPEX for the spoke. So somewhere close to about 30 crore OPEX and 70% of that being generated by delivery of care for following the same kind of model that we follow in travel business. That it's the same train going from Mumbai to Delhi or same plane taking you from here to London. There are some people who have paid a lot more in a slightly different environment. And there are some people who have paid very little, and yet they would reach the same distance, same destination. The time taken would be similar. So on the same lines, if we were to deliver optimum care, state-of-art care in different inhabitation, or rather environments, and right from free treatment to a fully paid treatment, depending upon the choice that the patient exercises, we would be able to generate fair amount of revenue and see to it that the OPEX remains as low as possible, which is obviously liked by all the revenue and finance secretaries, not only in India, but any other country that would be the case. We also know that we are the pharmacy for the globe. Look at the cost of various molecules that are presently available, and that's the reason why the access to care is much better, because of the low cost of the drugs, the generics that are manufactured in India, which are presently exported all across the globe. Let me take you to the model that is followed in Tata Memorial Center. And the model essentially looks at three components. I'll first touch upon the last component, which I alluded to in my previous slide, that we would want to treat the whole spectrum of society, so that we look after the poor, we look after the middle class, we look after those who can afford to pay. And that kind of spectrum allows us to understand the cancer biology as it interacts with social class, as well as the outcomes, depending upon those factors. And then the gaps are much well understood, rather than in a very lopsided delivery system wherein this institute is a poor man's place, that institute is a rich man's place, and then we are looking at only part of the elephant and saying that this is what I have understood. So it is for this reason that this model I feel is much better, and it is not a surprise that in the last decade or so, there have been at least about 8 or 9 major study results emanating from this institute that has changed global clinical practices. For running of the government, the institute, we have 2 simple principles: that there are 2 non-shareable commodities, if I may use that word, patients and the income generated out of patients. And if a patient comes to me, obviously somebody else is not going to get that patient. So there should be strict governance in distribution or use of delivery of care in these 2 areas. So we have disease management groups, each one, whether it is surgery, medical oncology, radiation oncology, would confine ourselves to an area so that everybody is guaranteed that all patients with that disease would come to me. If it's breast cancer, would go to somebody else. If it's colorectal cancer, and I don't have to worry about somebody else robbing me of my patients. The income generated gets into a common pool, and depending upon the research outputs, and I go on to the next principle, that if I do a research, it's in public domain, everybody can follow it. So it's a shareable output. So there is an incentive for that. Based on the research outputs, the amount of money that is generated out of the common pool of share in hospital income is shared amongst the doctors in the institute. So those who get a much quicker rise in grades because of their research output would get much higher share of the same income. With this, we've had about anywhere up to about 3 to 4% attrition annually, which I feel is healthy. Although there are some unhealthy years in between, we suddenly find that 8-9 people leave us and then we are in search of individuals. But this has worked well for the last 20, 30 years, and I'm sure it will work well in years to come. We do have some ways and means of finding that we are doing well, and the documentation is there. We run paperless, so everything is documented. I know precisely, sitting in my office, or any head of the department knows, sitting in his office, what's happening as far as patient care is concerned. And each of the disease management groups are told that this is the total number of patients that they're treating. It should be available in the intranet or on internet. What's the 30-day complications of whatever treatment delivery that is being given? What are the guidelines do they follow, and the compliance to guidelines? And what's the 5-year survival of patients treated in the unit? And finally, is there any original research that has changed practice? For each of those, starting from 1 star for the first completion, a unit becomes a 5-star by the time the last point is satisfied. That's only to keep the good QA/QC in each of the units. I finally turn on that whatever we are doing, we feel that we should be better tomorrow rather than what we are doing today. And towards that, what are the affordable solutions which we have looked at, and the solutions that we have explored as part of research projects. I'll give you few examples here. But essentially, as part of National Cancer Grid, as well as what we follow in our own 7 or 8 centers, is multi-centric collaboration. So infrastructure to run multi-center trials. Invest into common as well as some unique cancers, and I'll give you some of the examples of those. Cost-effective solutions to be explored. Creating infrastructure to run that research endeavor by way of CRS, Clinical Research Secretariats, as well as by way of creating human resource. May it be clinical research methodology individuals or navigators who will see that compliance is adequately maintained. And while doing all this, we involve society into it. And I do find that any healthcare facility, if it has societal stake in it, that much better chance that it will function well, and that much better life that it will have of sustainability. We have gallbladder cancer as a unique cancer, and here is an example. Unfortunately, this cancer, those who get it, almost 95% die within the first 3 years of diagnosis of this cancer. We have had a 1,300 or over 1,100 patients data wherein we looked at what is so unique that this cancer affects the Punjab, Uttar Pradesh, Bihar, we now know Orissa, and whole of Northeast, and it's not there in any other parts. So in these states, the incidence is somewhere close to about 20 per 100,000, and the same incidence in Mumbai would be 0.02 per 100,000. So huge difference between the two. And we were looking at, is there a genetic variation that is allowing it to happen? And we did find that over and above women and a few other risk factors, one of the risk factors was an abnormality in ABCB1 and ABCB4. These are transport proteins. So as if because of that abnormality, there is a gate that is open and something is entering. We are now in search of what is it that is entering the cell, and can we plan some studies related to that. These results were, after being published, were reproduced in the Chilean cohort subsequently, and we now know that it is common everywhere globally. If we were to apply this and then screen individuals, we would get a group of population that has 20 times greater risk than the general population. So we need not waste the screening modality in huge numbers, again, to reduce the cost if we were to screen any individual. The progesterone study is well known, again, single injection changing the outcomes. That's the perioperative region where we have invested fair amount of money in the breast unit. And a fairly large difference by perioperative progesterone in a subgroup of individuals that were node positive, which is presently implemented in Tata Hospital. And there is another study that is happening outside of Tata Hospital to reproduce that data. This was presented last week. Very tumoral again, an intervention which is at the time of surgery to prevent metastases, showing a fairly large difference in the outcome of disease-free survival as well as overall survival in all comers of early breast cancer. Suffice to say that we are looking at short-term interventions which are low cost, and if they give even 5 to 4%, 4, 5, or 3% improvements, implemented across the country would have ease with which it can be implemented and would have a major impact in reducing deaths related to cancer. We do need to look at what can be done with the least cost to improve our health, and that will have a major impact on economic growth of our country. And I would end with the thought that healthcare delivery is not a business, and I say that it is not a business because I cannot create disease in society. I cannot increase my customer base if patient was to be called a customer, because my existence in society is towards reducing disease in society. So I work towards my own irrelevance, and under that business, it can't be then a business. But as far as transparency, as far as QA/QC, as far as all other aspects of business are concerned, they need to be followed to the last word. Thank you very much.